Okay, folks, we'll go ahead and get started. Thank you all for being with us today. We apologize for the small room. There are a lot of meetings going on today at this particular time, and this is the hand we got dealt in the smaller room, and I'm sorry that some of you don't have seats, but maybe you can look around. There might be a couple of extra seats. Some of you could be a little more comfortable or something. But anyway, we'll go ahead. Let me remind you that, of course, we'll have hearings today and tomorrow. And in room 245 over at the Capitol, we have a sign-up sheet. But tomorrow afternoon, after the presentations, we'll have an opportunity, if anybody that wants to have some public input into the meeting, they'll be able to sign up and speak for a few minutes on any of these issues that you wish to talk about. So if you would, please go by there and sign up on the sheet. It's in room 245 over at the Capitol. And tomorrow, just to remind you, we'll be meeting in room 506 over here at CLOB at 2 o'clock. So maybe have a little more room over there maybe. But anyway, having said that, let's go ahead and begin. And we'll begin from hearing from Commissioner David Cook, Department of Community Health. Commissioner?
Pleasure to be here today with all of you. We have a number of slides that we had presented during the joint presentation and the presentation that we made last time. I'm going to skip most of those context slides and get primarily to the budget. I think most members of the committee know about DCH and the fact that most of our budget are two large health plans. The biggest one, of course, is Medicaid, and this is slide 5. I think we'll just go ahead and skip to slide 5, but let me just, as an introductory comment, indicate that, again, we're very pleased with the fact that we had made some significant progress in terms of putting the state health benefit plan on sound financial footing. There were a lot of steps that were taken there that I think were significant steps, and just to remind everybody, we still have a ways to go with regard to that. We've got a $62 million. We reduced that deficit from $815 million to $62 million over a 2-year period, and we still have work to do there. So we're going to begin working on that in earnest very soon. And the other thing I would just emphasize is that we continue to, from the department, in the department as well as to stakeholders out there, look at ways that we can reduce bureaucracy in what we do and to make life easier for those people that participate with the program. So we always encourage those ideas and for people to talk to us about that. In terms of Medicaid and the pie chart, let's go back to the pie chart. We have the DCH budget is $11.2 billion in total funds. That's with federal and state. You can see a lot of that is federal money, only $2.4 billion in state funds, and of course you're aware of the other programs, Peach Care for Kids, Administration, Health Access, etc. Really are small, very small percentages of the budget. Medicaid is 95% of the budget. So what I'd like to do is skip the context slides and move all the way to slide 11, which is the budget itself, and maybe that will save a little bit of time for more questions, etc. at the end. And I'll just run through these. This is, again, the FY13 proposed budget. There we go. That's better. The FY13 budget, the base being $1.338 billion. Item 17.5.1 is the funding that we have projected for program growth. That was $19 million. Item number 2 there is 17.5.2 reflects funding that we hope to receive through a federal program called the Balancing Incentive Payment Program. That's a program to help get an enhanced FMAP rate for moving people out of institutional settings and into the community setting. Item number 3 is moving the nursing home providers to the 2009 cost report. It was at 2006. This would move it to 2009, and that would be for about $21.5 million. Item number 4, to provide funds. You'll see a couple of these throughout the this is the ABD population. You'll see this in low-income Medicaid as well as Peach Care, eliminating the 0.5% reduction in provider payment rates in the ABD population. That's a cost or additional expense of about $1.5 million, reducing the or paying co-payments or collecting co-payments on the nearest dollar amount rather than having to make change in would be an administrative ease at the behest of the provider community. That would add about $1.4 million in the budget. Item number 6 reflect savings from our program integrity efforts. It would reduce costs by about $4 million over the course of FY13. Item number 7 is increase the $35,000. This relates to our projections for the nursing home rates and the provider fees collected there. And item number 8 is to increase funds to reflect the less favorable FMAP rate. That went down a little bit, so we need additional state funds to account for that at about $9 million. So that's the ABD portion of the budget. Low-income Medicaid has several of the same items. This is on page 13, slide 13. You'll see the 5% reduction, or eliminating the 5% reduction for providers. In the LIM area, that would be about $3.1 million additional funds. Reducing the co-payments, that was about $360,000. And we replaced some of the general funds with tobacco settlement funds, $8 million in that particular item there, which is 17.6.3. The next item, point 4, reflects the LIM change in the decreased FMAP participation rate, and that's almost $8 million. Item number 5 is to restore funds from low-income Medicaid. Last year, those funds were moved out of low-income Medicaid in order to pay for other high-priority items in the budget, and so this would be restoring those funds for FY13, $77.5 million. Item number 6 is to reflect our preliminary projections on the hospital payment revenue. That's about an additional $11.1 million. Item number 7 is our growth projection. In the low-income Medicaid, we're projecting growth in about $3 million. In item number 8 is to restore the capitation payments for the CMOs back to the original 12-month pay structure, and that is about $75.6 million. So you can see the change in the LIM, net change of an increase of about $179 million, or a 19% increase. And again, that's, I think, the two big items there are restoring the $77.5 million and paying to make current the capitation payment rates. Those are probably the two biggest items. Peach Care for Kids is has, again, many of the same items. Restoring the 0.5%, eliminating the 0.5% cut for providers at $349,000. Doing the even dollar co-payments costs about $229,000 in Peach Care. Item number 3, to provide funds for provider rate increase. This is the item where we had moved, in moving or offering Peach Care enrollment to state health benefit plan participants. We would see a decrease in the provider payment rates between the SHBP payment rates and the Peach Care rates. And so what we wanted to do is to try to equalize that, restore that amount so that the provider community would not take a hit in terms of treating those Peach Care patients. And so we added $4.6 million, which, and I want to thank there are a number of people that worked on this to come up with the E&M codes and the DRG payments to basically make that whole. I think we commend everybody for doing a good job on that. Item number 17.7.4 is to increase funds to reflect the decreased FMAP rate. Item number 5, to provide funds for the projected enrollment. We do project an increase enrollment from the state health benefit plan enrollees, and that would be about $8 million in additional expenses to the Peach Care for Kids program. Item number 6 is our growth projection of just under $4 million, which is separate from the growth projection that we had related to the Peach Care movement. Item number 7 is the CMO capitation payment portion for Peach Care for Kids, and that is about $6.5 million. So that concludes the Medicaid and the Peach Care portion of the budget, and maybe this is a good time to stop and ask for questions, or be happy to proceed into state health benefit plan.
But any questions at this point from members of the committee before we move into the other presentation?
Thank you, Mr. Chairman. State health benefit plan. We'll skip to slide 26, I believe it is. You've seen the other context slides before. In the FY13 budget, one of the things that we're doing, which I think is going to be a significant improvement in terms of administration, is to move to a direct billing for employers, so it's a per member per month rather than a percentage of payroll. So that's an administrative thing that we'll be doing. There are no dollars connected with that in this budget. 17.8.2 is to increase the employee premiums, which we have done previously. I guess that went into effect January 1st. 6.2% related to the costs associated with some of the mandates in the Affordable Care Act related to covering children age 26 and 100% coverage of preventative care are the big items associated with that. Item number 3 is a reduction of about almost $3 million for changes in the Medicare Advantage plans for our retirees. Item number 4 is a savings of just under $5 million from eliminating the vision benefit under the HMO plan. Item number 5 reflects savings related to tiering of prescriptions in the health reimbursement account plan. That's a savings of almost $69 million. Item number 6 is to reflect savings from changing out-of-network provider payments to 110%, reducing it to 110% of Medicare. That was a savings of $33 million. Item number 17.7.8, the last row there, reflects savings from the voluntary mail order drug program, and that was a savings of about $1.5 million. Continuing on to item 8, reflects savings for implementing the specialty drug benefit. That's $3.8 million in savings for that change. Item number 9, to reflect reduced expenses in the transition for eligible members to Peach Care. That's what I referenced earlier. We save in the FY13 budget about $32 million as a result of that change. Item number 10, to reflect reduced expenses for offering the TRICARE supplement. That saves about $3.5 million. Item number 11 is to implement a tobacco cessation program in the state health benefit plan at an additional cost of about $2.8 million. Item number 12 is to eliminate the bariatric surgery benefit, about $3.5 million in savings in FY13. Item number 13 is the wellness program. We had in FY12 an additional cost associated with implementing our wellness program. We expect to begin seeing some savings with regard to that in FY13 of almost $29 million. Item number 14 is that $62 million I referenced earlier. That's the work that we still have to do to find additional savings in the state health benefit plan going forward, either through premium increases or employer increases or changes in plan design to accommodate that $62 million. Item number 15 just reflects our updated projections of a reduction of $116 million. Item number 16 relates to the employer funding for the state health benefit plan. That's the workers' comp and our own health insurance increases associated with that. Item number 17 increased the per member per month billing for non-certificated school service personnel from $296 to $446 per member per month. Actually, number 18 and 19 are in different chronological order. Number 18 calls for a $150 increase from $246.20 to $296.20 in September of 2011, and in July of 2012 we would see an additional increase of $150 per member per month, and that's reflected in item or line number 17 there, and you can see the numbers generated from that. The net change in the state health benefit plan is a decrease of nearly $100 million from the base. The revised base is $2.9 billion, almost $3 billion, a reduction of 3.2%. Health facility regulation is a pretty straightforward budget. The only line item in this budget is a change for the statewide changes reflected in workers' comp, etc. That is an additional $193,000 to reflect those changes, and we're also consolidating on in the program area other programs related to healthcare access, so that it's all together in one place in the budget, and that reflects an additional expense of about $1 million. So the net change is $1 million, $1.2 million, for about a 20% increase in health facility regulation, primarily from just moving that program to health facility regulation. Finally, in DCH administration, we have had substantial reductions in the administration of DCH over the years, and this shows the reduction in funds that go to DCH issues only. It does not include public health, which we had moved out this year, and we took a look at this from a pure DCH perspective, so that's down about 40% since 2009. It's interesting, I might just as a side comment here say that DCH over the last 3 or 4 years has had a lot of movement in and a lot of movement out, and I feel like the department is now getting settled in, and we're going to be able to dig in on some of the ways that we can look at providing the services that we provide and administering the department in a more efficient and effective way. We have done some reorganization along those lines. Earlier we had moved the Certificate of Need program into health facilities regulation. We were able to reduce a couple managerial positions related to that and are getting some economies of scale and efficiencies related to that. We're moving some of the Medicaid reimbursement and finance out of Medicaid and into the finance division, and seeing some improvements there in terms of catching up on some of the things we need to do post MMIS conversion. So we're going to keep pushing on that and continue to push on gaining administrative efficiencies within the department. In the budget, I will start with the state budget in terms of administration is about 63, almost $64 million. The statewide changes related to administration are just under $1 million. Item 17.1.1, we transfer funds from the Office of Health Information Technology to healthcare access. There's a reduction there of $500,000. You saw that reflected in the health facility regulation portion earlier. 17.1.2 is the one-time funds to evaluate our reimbursement methodology for outpatient hospital services. Excuse me, we are continuing to look at ways that we can simplify what we do and what we call for from the provider community in order to make cost reports and other things that we need much more administratively simple. This is one that we think holds a lot of promise. We've gotten a lot of favorable feedback on this, and so we'll be pushing forward on that and seeing if we can't bring that to fruition by next year. Item number 17.1.3 is one of several mission-critical projects that we have at DCH, and it seems like we continue to have more and more mission-critical projects the closer we get to January of 2014. This one, item number 3, relates to ICD-10, which is a large IT project that relates to our Medicaid payment system. The ICD-10 project mandates, federal mandate, that we convert codes. We currently have about 18,000 billing codes that are in our MMIS system, and we have to convert that to about 140,000 codes. So it is a major IT overhaul. We're pushing hard on that. We're on track to complete that project in a timely way. You may have heard of 5010, which is the precursor to ICD-10. That is, we are ready to go on that, although CMS delayed implementation of that till I think April 1st, which is again a change in the coding methodology. Under federal law, no Medicaid or private sector commercial claim can be paid unless it's 5010 compliant on April 1st. We are ready to go on that. It's the same kind of thing for ICD-10 beginning October 1st, 2013, and we're on track to be ready for that as well. Item number 17.1.4 relates to the assessing the Medicaid managed care program, our Medicaid redesign, and our consultant there, Navigan, has just issued its strategic options report, and we're going to be continuing on with this project over the course for the next year to year and a half through implementation, which we hope will be implemented by January 1st, 2014. Item number 5 again relates to program integrity. We're putting some additional funding in the administration to our program integrity, about $2 million. You get about a 4-to-1 return on the investment of those dollars, and so we're looking forward to improving what we do there. 17.1.6 is our 2%. I should have mentioned this earlier. The governor had asked state agencies to reduce their budgets by 2%. Medicaid and the state health benefit plan were not included in that. However, our administration and I believe health facilities regulation is also included in that. And you can see here where we save fundings by reducing operating expenses and some of the contractual services that we had typically had in the past. So that's primarily where we get our 2% reduction in savings. So with that, you can see a change of about $4 million increase in administration at DCH. Virtually all of that is connected to those mission-critical projects that we had talked about earlier. And that's an increase of about 6.3%. With that, Mr. Chairman, I will stop and answer any questions that you might have.
Okay. Do we have any questions from members of the committee? Representative Stevens.
Thank you, Mr. Chairman. Looking at 17.8.14 and 17.8.15 together is about $179 million. And the explanation is to identify additional plan design and or revenue strategies to cover projected FY13 expenses. That's a pile of money.
Yes, sir.
Are we going to get some sort of enlightenment on how y'all might like to get there at some point?
Yes, sir. Absolutely. It is a pile of money. I guess the only bright spot is that it sure looks a whole lot better than $815 million. And, you know, I was actually looking at some of the documents that we had generated early on in this process today. And we have implemented well, you see a laundry list. Most of all these changes have already been implemented. They were either implemented last summer or on January 1st. And I don't have any answers for you today. What I obviously will keep you in the loop on what we intend to do. The state health benefit plan has gone through a lot of changes. There were a significant number of changes before my coming on board in terms of plan design changes. And unfortunately, every 5 years you have to recalculate the assumptions that our actuaries use, and we lost a lot of those savings based on different demographic projections, people retiring and those kind of things. So we have a ways to go on this, there's no question. And my hope would be that we're also, one of the changes that we have is we're doing much more frequent projection updates. So I think, when is our next SHBP projection? It's March or April. So as we get those, we'll have a clearer idea of exactly where we need to go. We've had a lot of plan design changes. It would be my goal to try to hold tight and let those plan design changes work as much as possible. We've had significant amounts of increases in terms of the employee increases. 17% this year, which is a significant increase for employees, and that has occurred throughout the last several years. And quite frankly, the funding problem that we have regarding the state health benefit plan relates to the non-certificated area, where we were just not collecting from the employers sufficient amounts. So I know we have a 3-year plan that we've laid out for that. We're going to try to keep to that, but those are all the various areas that we need to look at.
You inherited a big hole. Appreciate what you're doing.
Thank you, sir. Look forward to working with you.
Representative Gardner.
I have a couple of things that are probably not a pile of money yet, but I wanted to understand. I'm extremely concerned about the growth of diabetes in our population, and on 17.8.12, eliminate the bariatric surgery. Can you tell me what the justification is for that, given the high incidence of diabetes and obesity in our state?
Yes, ma'am. I can. I guess I would go back to the earlier comment that we're looking for. We had a big hole, pile of money, $815 million in April of last year that we were looking to save. And we made, as you can see, a significant number of plan design changes here, and did focus on one of the biggest plan design changes that we made was related to a wellness program. So with a focus on wellness, and to try to move the needle in terms of changing behavior and getting healthier people so that we reduce costs that way. So that was probably the most significant thing that we did, and so there was a heavy focus on wellness in what we did. And as I also mentioned, we had some pretty significant increases in premiums. And we also fought for some increases in the employer premiums, as I just mentioned, regarding the non-certificated, and that area was underfunded. So when this issue came up, we looked at it. Number one, there were some immediate savings associated with this. Number two, there was a relatively small number of people that were impacted by this change. I think in the last year that we did this, in calendar year 12, there were about 370 people impacted on it, as relates to the entire population of nearly 700,000 patients. So the change affects a very small number of people. That was part of the thinking. The other is that the surgery is, and the benefit is, an expensive benefit. It's about $20,000 to $23,000 per surgery. And when we looked at this in terms of future savings, we have, and I would caution that this is not a lot of information. So we have a small number of people. Over a short period of time, we have the benefit for, I think, 3 years. So we looked at our experience over that 3-year period and sliced it from both medical as well as pharmaceutical expenses, and saw that our expenses were up just slightly in terms of that very small experience. Now,
I'm surprised it's not part of the wellness program. I mean, it is
the savings. I'm not sure that I guess that was the other part of the thinking, is that we were not real clear in terms of how much long-term savings this benefit provides.
So you don't know about the outcome research.
Right. Now, I think there's a good argument to be made for that, but you know, we've got another 1.6 or 62 million to go, and I think that's part of the thinking. So,
I have another question, Mr. Chairman, if I can. 17.8.8. It looks like they're kind of parceling out of the prescription drug benefit, and this seems like a very specialized kind of a contract, and I just wondered if you could tell me a little more about that and who the vendor is.
yes, well, the mandatory specialty drug benefit basically is for those specialty drugs, which are very expensive, unique drugs for cancer patients. I think and others. They're usually administered within a physician office, and the change here is to use one pharmacy for that. I would have to turn to should be on that.
And so you can demonstrate to us some savings as a result of using that one specialty
By purchasing it through one
vendor,
through one pharmacy.
one pharmacy.
Right, essentially. I believe it's an out-of-state, that one vendor. Okay.
So United has a vendor and Cigna has a vendor? And perhaps you can get me the name of those vendors for another. So Prescription Solutions, and the other one is Cigna use?
Cigna?
No, it's also an in-house
So it's
specialty.
within the two vendors.
Thank you.
Thank you, Mr. Chairman. My question was actually relating to the one that Representative Gardner had addressed or brought up earlier. I just wanted to make sure that I heard you right. Regarding the bariatric surgery elimination, we're showing a savings of $3.5 million, correct?
Yes, sir.
I just wanted I wasn't sure what you said. Have you said you have done an analysis to show what the actual savings would be? Because I would assume that there are significant costs in otherwise treating these people who are diabetic and obese. So
There may be long-term savings,
Mhm.
and we can go back and take a look at that, but I did not see a strong case for long-term savings in either what our experience was or in some of the other plans.
Okay, follow up, Mr. Chairman.
These are, I think, part of what our experience has been, and others too, is that these are probably the most difficult patients for a surgical patient, being the overweight patients, and we had several patients that ended up being on ventilators and had long, expensive hospitalizations as following the surgery. So it's higher risk, and it can be a very expensive proposition, which offsets the savings for those successful patients down the road.
I was contacted a few weeks ago regarding it, not by a lot of people, but enough to put it on my radar, and that's I was looking into it a little bit. I think it's something I'd like to maybe talk with you about a little later.
That'd be great. Just additional information is about 30% of the commercial sector plans cover this option. Only about 10% of fully insured plans cover bariatric surgery. So on the commercial side, a minority of plans cover this benefit. There is on the state side, I believe a majority of states do cover this.
Majority of states do. Do you know?
State plans, public
Quick
plans.
question, Mr. Chairman. Do you know what percentage of plans covered? 30, you said?
30% of private plans cover bariatric surgery. About 10%.
Do you have a
fully
list of
insured.
those? Because
I'm sure we can get you the
because
information that we have
to,
on
to
that.
me, I mean, that's great unless the 30% is Blue Cross, Blue Shield, Cigna, and United, the big dogs, because there's so many kind of boutique smaller, and I mean that can kind of skew those numbers. And, but it would be an actual lives versus percentage of carrier.
One of the things we are doing is looking at what are the, and probably this is more true in the commercial area than in the state plan area and public sector, but looking at the innovations and the new things that are coming on board to address any variety of issues, including disease management and those kind of things. So we'll be happy to get you that information.
Thank you.
Thank you, Mr. Chairman. Commissioner, slide 26 on page 13, item 17.8.5.
Yes, sir.
It reflects savings from implementing tiers for prescriptions in HRA plan, saving of $69 million. Can you help me understand how that works?
That is, I believe there's a different co-payment regarding each of the three. There are 3 tiers. I don't believe we had a tier system set up prior to this year, and I guess maybe that was implemented in July.
So is it? So you have different levels for different drugs, is that? So is that? So is that the reason I have taken one drug personally? It was $30 copay, and now it's $80. Is that that's what that is?
Yeah.
Okay.
Yeah. A lot of these things, I guess, I would point out too is in addition to increasing premiums. There are other ways to generate revenues from the people that belong to a plan through co-payments and other things. So I think we try to look at that as well when we look at both plan design changes and where we need to try to set premiums in order to strike a balance there.
Thank you. Thank you, Chairman Parrish. I certainly appreciate your presentation there. I too had some reservations about the bariatric surgery, doing away with that. I mean, generally it's been cost effective, and 3 years may not be quite long enough to track whether or not that's saving enough money from diabetic, hypertensive, hyperlipidemic patients on medicine. So that may be something you want to look at. But I will tell you, other than that, I think that's been covered well. Is the governor mentioned in his State of the State about increasing residency spots, about 400 spots over the next, I think, 4 years, and the seed money, is that in the 17.91, or is that in a different place?
That's in a different place. That's in the Georgia Board of Physician
Board of
Workforce.
Okay.
Board of Regents.
Okay. Is that not so? Can you explain to me what this 17.9.1, or no, I'm sorry, 17.10.1 maximize federal participation for graduate medical education? Okay. Thank you.
Thank you. Following up on the tier, it'd be interesting to see what you learn happens to the state employees who find that their medication is no longer $30, but it's $80. I mean, we know Representative Chanel may be able to afford that, but I'm not sure all state employees can. I have a couple of questions. Back on page 7, I have heard some concerns expressed about the projected growth in the Medicaid program. This is 17.6.7, I guess. Is that enough to reflect the growth in the Medicaid program? I think I'm on the right place.
For low-income Medicaid in FY13. We have a projection that DCH has, and we work with OPB on that projection. We believe that's enough, although it's very it's cutting it close. It's interesting. We pay in Medicaid, both low-income Medicaid and ABD, $36 million, or a little bit more per day. That's both state and federal. We pay about 10 point something million dollars in state funds per day in Medicaid. So when you look at a almost 11 billion or $8 billion program and look at reserves and growth, et cetera, it can change pretty substantially given factors out there in the environment. Those are the best projections that our staff in working with OPB have.
At some later point, it'd be interesting to see the projections and the actuals for the last couple of years to see how accurate you think that might be. One more question, if I can, Mr. Chairman. On the next page, page 8, 17.7.5, moving the state employees into peach care, low-income state employees. Appears that the state's going to have to spend $8 billion. What will be the revenue that will be generated? Oops. All those zeros confuse me.
That would be, if you look on the other side of that is on the state health benefit plan, 17.8 oops, I thought I had it.
That's the savings, is it?
Yep. 17.8.9, $32 million.
Well, that's important. And what I was curious about what federal dollars will come as a result of our spending that $8 million.
Yeah, and this is just the state money, so it'd be 2/3.
2/3 more,
2 to 1.
so.
3 to 1.
Yeah. So with 32 million in revenue is what you're saying.
32 million in less costs for the state health benefit plan, and we'll be able to cover those in peach care for right, I see what you're saying.
But for the state, for the doctors and hospitals who need to get paid, it will be an additional revenue source. Because the federal government will be paying a portion of the bills.
We'll be drawing that money down on the state side to make that payment. That's correct.
That's the point I was trying to make. Thank you.
And then what we tried to do is to even out what those reimbursement rates would be, so there wouldn't be a reduction from state health benefit plan to peach care rates.
And the pharmacists too. Yep.
And the pharmacists.
Any other questions? Commissioner, talk to us a little bit more. You mentioned this in your presentation, going to this code changes that are going to be occurring and going from 18,000 codes to 140,000. I mean, I know that's going to be a gigantic undertaking. And what concerns me is all these providers are sort of hanging on by their fingernails, and if we disrupt that cash flow there because of some glitch in the system, it could really have some devastating effect, I think, on a lot of our folks. Talk to us a little bit more. I know y'all are working on that, but you feel like we're making the proper progress we need to be to make sure that we do this and we don't have a breakdown in that system as we move forward.
Yes, sir. I'm very comfortable, and I guess I'd use the 5010, which is the precursor to the ICD-10, is what you're referring to. The 5010 project, we were ready to go and processing claims appropriately by the target date, which was January 1st, 2012. We at the department had a very aggressive campaign in reaching out to the provider community to say, please send us test claims. We had a lot of hospitals that did that. We had a lot of doctors that did this as well. And I think one of our experiences in the MMIS conversion was that we found testing is key to make sure that we're doing it right and trying to get those glitches out. So we've been very aggressive, not only in terms of testing, but in reaching out, and we know who's compliant with 5010. And I got a pie chart every 2 weeks from our IT folks, how many providers are out there and what percentage of those providers were 5010 compliant. I'll tell you that we probably still have about 15-20% of the provider community, and I haven't looked at it in a while, that is not 5010 compliant. And when April 1st comes around, I will guarantee you that DCH is ready for that. Not every provider in the state of Georgia is ready for that. The lift for ICD-10 is much, much greater than 5010, particularly for the provider community and those that are in rural parts of the state that don't have the capability to do the IT changes that are necessary. So I guess I believe the department's going to be ready for that. We will use the same process, being very aggressive about testing it. We'll be very aggressive about seeking out those providers that we think may not be ready and encouraging them and helping them to get ready. And but it's a big issue for all of us.
Remind us again the date for the ICD-10. Did you say?
ICD-10 is October 1st, 2013.
October 2013. Okay. Any other questions? Commissioner, thank you.
Thank you, Mr. Chairman. Thank you, members.
Okay, we'll give them just a minute here to change over, and I think everybody will be able to find a seat. Thank you. Yeah. Okay, folks, we'll move along now. I think everybody's had an opportunity to relocate, and everybody's got a seat out there, so we're okay. Next, we're going to hear from Sherry Tucker, Executive Director for the Georgia Board of Physician Workforce. Sherry?
Thank you, Mr. Chairman, for having me here today. I'm going to go over our budget, which on your tracking document is on page 3, starting with 17.9.1, the board administration. This is a transfer of funds within the administration to the Physicians for Rural Areas program of $40,000. 1710.1, our graduate medical education program. The recommendation is to maximize federal participation for graduate medical education programs. The governor's recommendation was yes on that. 1710.2 is transfer funds from the Morehouse School of Medicine operating grant to the graduate medical education program, which is an increase under GME of $1.4 million. 1711.1, reduce funds for the Mercer School of Medicine operating grant. That's a reduction of 2.1%, which equates to $417,454. 1712.1 is the actual reduction to the Morehouse operating grant of transferring the funds to the graduate medical education program, the $1.4 million. 1712.2, reduce the funding for the operating grant by 2.1%, which is a separate reduction of $220,865. 1713.1 is the transfer of the $40,000 from admin to the Physician for Rural Areas program. That's the $40,000, and that will fund for 13 either two additional medical school scholarships or loan repayments for medical students or physicians to practice in Georgia counties of 35,000 population or less. And 1714.1 is reducing the funds in undergraduate medical education, which is a per student, per Georgia resident rate, paying for students at Mercer, Morehouse, and Emory, and that's a 2.1% reduction of $56,537,000. So I'll be glad to answer any questions.
Okay, Representative Hughley, you have a question.
Thank you, Mr. Chairman. Thank you for the presentation. Let's talk about this transfer of funds from the Morehouse School of Medicine, this $1.4 million. Tell me about that, and what are you actually going to do with the money when it gets to you?
This was a governor's recommendation, and this assumes the continued availability of the federal match for the operating grant, which is currently passed through 4 hospitals, Grady, South Fulton, Southern Regional, and Atlanta Medical Center. And the recommendation begins to align the funds per student between Mercer and Morehouse and moves toward the governor's long-term goals of ensuring program equity and sustainability. So it was moved out of Morehouse and moved into GME. The board has not really determined at this point in time how the money would be spent. I've come up with several projections that are going to be presented to the board to increase the current capitation rates we pay for the various specialties under our GME program. They've been cut well over 20% the last 3 or 4 years, and start moving those back up. Another thing we could do is to start a capitation program for specialties we don't cover right now, such as general internal medicine, cover a percentage of those residents, capitate them to help those programs offset their cost as well. The board has discussed in the past the starting like an incentive or reward program for those programs we have under contract that are well above our deliverable of 50%, retaining 50% of their graduates in state. So picking a level of 65-70% of their graduates, offering them some kind of incentive reward for keeping those grads in state and practicing in the areas where they're needed.
One more question, Mr. Chairman. Let me make sure I understand. You're telling me that we're going to send you $1.4 million and you have no plan as to how you're going to spend it?
It was just put in our budget when the governor's recommendations came out, and so the board has not had an opportunity to determine how those funds will be spent.
And then what is Morehouse School of Medicine supposed to do?
They are working diligently to retain those funds and keep the cut from happening on that.
Thank you, Mr. Chairman.
Thank you, Mr. Chairman. I was excited when the governor gave his state of the state that he was adding additional residents. Clearly, we all know that that's what's going to build the workforce of physicians in our state, but I don't see any in this budget.
That funding was put in the Board of Regents budget under the Regents Central Office and not in our budget.
Do you know why that happened?
No, ma'am. It's the governor's recommendation.
Some point of somebody to help us explain.
Any other questions? Okay, thank you. I think everybody is of the opinion that we need to do all that we can to increase the number of residency slots so that we can keep our Georgia citizen students in the state, because we all know that once they go into their residency program, if they go to school here, to the residency program here, the chance of them staying here is very high, as opposed to if they go out of state or go somewhere else to do their residency program. So
Correct.
we want to work with you on that, and I think we're all trying to get to the same place. We may just have a different way some of us are getting there. Okay. Any other questions? Thank you. Okay. Next on our list, LaShawn Hughes, Executive Director, Georgia Composite Medical Board. There she is.
Thank you, Mr. Chairman. My report will be brief. I represent the Georgia Composite Medical Board. We license physicians, physician's assistants, and those resident physicians also, respiratory care professionals. We're 17.15.1. We're reducing $5,000 from our budget. It says rent, but we're moving that to personal services. So it's $5,000 that we're deducting from our budget for personal services. I'll be happy to answer any questions about the board.
Any questions? Well, you must have done a good job. There are no questions. Thank you
Thank
very
you.
much. I want to thank everybody for coming. We'll remind you that we'll be meeting tomorrow at 2 o'clock in room 506. And if anybody wants to speak during the public hearing part of that at the end of the program, they need to go by room 245 in the Capitol and sign up so that we can get you on the program. Thank you very much. We're adjourned.